In case of diffuse parenchymal lung disease, or what we call interstitial lung disease, we do not often do lung biopsy because it is invasive. We diagnose based on the pattern of inflammation and fibrosis we see on high resolution CT scan of the lung. So there are many patterns of inflammation and fibrosis in high resolution CT of lung. One is called UIP pattern, or usual interstitial pneumonia pattern. So initially if you go back in the history why they call it UIP pattern, initially they thought that it is interstitial pneumonia and it is a typical interstitial pneumonia, so they called it usual interstitial pneumonia. But later when they started studying other patients, then they found that there is other pattern as well, so they called it non-specific interstitial pneumonia pattern. So this UIP, NSIP this is just a pattern of inflammation or fibrosis that we see on the high resolution CT scan. This is not a disease entity. So in a lung you can see both UIP pattern and NSIP pattern as well. In a single patient we can see in CT scan both pattern of inflammation and fibrosis. So let's talk about this pattern now. So what is NSIP pattern? In NSIP there is ground glass opacity and there is subpleural sparing. Subpleural means like in the periphery there is visceral pleura, and near the visceral pleura those alveoli are not involved, but beneath that it is involved. But if you see in UIP pattern there is subpleural involvement, and in UIP pattern you will see lot of fibrosis. There is even traction bronchiectasis due to so much fibrosis, and there can be fibrosis can lead to a honeycombing pattern. But in NSIP pattern there is just only ground glass opacity. So the prominent finding that you will see is ground glass opacity. So what is the difference between ground glass opacity and consolidation? So in ground glass opacity you will be able to see the vessels, the blood vessels, pulmonary vessels, capillaries, arterioles, right? But in consolidation you won't be seeing those, right? And if there is fluid in the pleural, then there will be completely opaque. So that's how we differentiate. So ground glass opacity means that it is not that opaque as consolidation. It is a milder version of consolidation. So you know, this NSIP pattern can progress to UIP pattern. There can be combination of both pattern in a single patient. So basically the take home message is that these are just pattern. This does not specify any particular interstitial lung disease diagnosis. You know, there are like over hundreds of interstitial lung disease. If you see the classification, there are more than hundreds, like occupational lung disease. If you see connective tissue disease related, ILD, right, hypersensitivity pneumonitis. So there are many diagnoses that we currently use. But basically what we see in those ILD is that how much inflammation is there and how much fibrosis is there. So if there is already fibrosis, then it is poor prognosis. Fibrosis means lung has been totally damaged and fibrotic tissue cannot exchange gas. So you have to give perfenidone, nintedanib, but even those drugs do not reverse the fibrosis. It might halt the progression, but if there is already fibrosis, then you cannot reverse it back. And in IPF there is rapid progression of the fibrosis even if you give the drugs. So some fibrosis progress slowly, some progress very fast. So there are different patterns or types among fibrosis. So I was talking that we have to differentiate whether there is inflammation or fibrosis. If there is inflammation, you can give anti-inflammatory like prednisolone combined with immunosuppressants like mycophenolate, azathioprine to control the inflammation, right? But if there is fibrosis, then we have to give these anti-inflammatory won't work. You have to give anti-fibrotic drugs. And if you can find out the percentage of fibrosis inflammation, then you can also predict the prognosis of the patient, how rapidly this ILD will progress. Because if there is tons of fibrosis already, then you can assume the prognosis, what will be the fate. But if there is inflammation, then you can be pretty confident that this inflammation most likely resolve, but you don't know whether it will go to fibrosis or not. In ILD there is in some cases there can just be inflammation, recurrent inflammation. You treat with steroid, mycophenolate, azathioprine, it resolves, it again recurs with certain antigenic exposure. You again treat, it again recurs. So it can never progress to fibrosis. There just be inflammation, resolving, relapsing, remitting inflammation. This can be one pattern of ILD. Other pattern can be rapidly progressing fibrosis that we call idiopathic pulmonary fibrosis. We still do not know what is the inciting antigen that is triggering this. That's why we call it idiopathic pulmonary fibrosis. And prognosis is like 3 to 5 years only.